Hello, good morning, everyone. So today we are going to talk about the stereotactic radiotherapy and its role in RCC. So currently we have enough evidence to justify the role of stereotactic radiotherapy in localized RCC and also in oligometastatic RCC. Now, before we understand and look at the evidences, let us see how does it work. What's the basic mechanism of a stereotactic radiation? So when we apply a high radiation dose of more than 6 or more than 8 gray, there are various ways it causes cell damage. One of them is the endothelial cell damage directly, that is endothelial apoptosis. The second is the biceramide or the sphingomyelinase release, which further cause the membrane damage. And third is the release of pro-inflammatory signal pathways. And these pro-inflammatory markers or the signals, they are going to cause cell damage. Apart from this, there is also direct damage of the tumor cells by the stereotactic radiation themselves. So these are the various ways how a stereotactic radiation are going to cause cell damage in RCC. Now, what are the evidences? We'll stick our discussion to localized RCC, and there are two important evidence which is available currently for justifying their role in RCC. The first of them is the Fast Track 2 study, which is the latest one published in March 2024. The Fast Track 2 trial included around 70 patients, and the most of the patients included were T1A and T1B disease. These were those patients who could not be operated or because of the medical reasons or because of high risk for surgery, and they were neither candidates for active surveillance. So these were those patients were included into these trials, and they made sure that the tumor was not encroaching or not abutting the bowel, and the GFR was more than 30. Okay, that means it was not CKD 4 or 5. And the tumor size, even it says up to 10 centimeter, was included. Majority of the patients were T1A and T1B disease. The follow-up was done for 43 months, that for the median follow-up period, and the primary outcome was to look at the local control rate, which was achieved in all the patients. And so was the cancer-specific survival of 100%. That means none of them died. The mortality was zero because of the renal cell cancer. The distant metastasis or distant spread was seen in up to 3% of the patients, and the kidney function loss was also very less, which was around 14-15 ml per minute loss in GFR in a follow-up of around 43 months. So this was the Fast Track 2 trial. The another trial which have a larger follow-up is the IROC study. We have the 5-year outcomes of this. And in this 5-year outcome, we find that the cancer-specific survival was 92%, and the local failure rate was 5, and the distant failure was just double of it. And the GFR loss was almost comparable to the last one that we saw in the Fast Track. So Fast Track and the IROC. So these are the two trials we should remember whenever there is discussion of stereotactic radiation and their role in localized RCC. Okay, we still don't have any RCTs comparing stereotactic radiation versus surgery localized RCC. That would be the highest level of evidence that we can have. But then these prospective studies and follow-up data that we have does show a promising result in the role of our SBRT in management of a localized RCC. Okay. Now, what are these guidelines? So these are ISRS guidelines or ISRS recommendations given in 2024 January in terms of the various parameters. Number one, what should be the optimal dose of the stereotactic radiations? So depending on the size of the tumor, if the size of the tumor is up to 4 or 5 centimeter, a single fraction of 26 gray is going to be sufficient. When the size of the tumor is more than 4 or 5 centimeter, then you need to give higher dose in more fractions, 42, 48 gray in 3 fractions, or if you're giving 40 gray, you might require 5 fractions. So this is regarding the optimal dose recommendation. And what about the follow-up? So you are going to do an imaging follow-up. And do you need to get a biopsy always in follow-up? No. You get a biopsy only when the imaging shows there is progression of the size of the tumor or there is any feature of progression, you get a biopsy from the tumor. Is it going to be efficient in solitary kidney? Yes, it is efficient in solitary kidney as well in terms of both local control and preserving the renal function. So not in CKD4-5 again, in local control preservation as well as renal function preservation, both these are efficient in solitary kidney as well. So these are the recommendations given by ISRS, and these are the same summary of the International Radiosurgery Consortium, the same things. So the majority of the patients included are T1A, and even T1B patients are eligible for this SBRT. And currently the patients who are included in the studies are those who are medically inoperable, are not fit for the standard of care, that is the nephron sparing surgery. So that is why we need RCTs that could compare nephron sparing surgery versus a SBRT in localized RCCs. Okay, so just to summarize, we discussed the mechanism, how an SBRT works. We discussed the fast track to study, fast track to trial, and we discussed the IROC trial and the ISRS recommendations. These are certain things you should remember whenever there is a discussion in your section 2. You can expect these topics to be coming up, okay, in your technology stations. They can ask on SBRT. These are something new, so they can potential scenarios in your section 2. Also, there are some ongoing trials. We just know the name of the trials. They might not be asked because we still don't have enough evidence from these trials. We still don't have result of these trials. Over the next few years, I think when we get the results of this trial, we will have more promising result of the SBRT. And this might be coming in the recommendations as well in the management of SBRT. For example, the Samurai trial, the cytoshrink and SOAR and probe trials. Some of them are very including SBRT versus immunotherapy and combination of SBRT with immunotherapy in management of oligometastatic RCC. So let's see the result of these trials before we can actually recommend them as a standard of care in localized or oligometastatic RCC. So for your section 2 exam, remember the name of the trials, remember the evidences that you need to quote, remember this IROC, remember the fast track 2. So even in your section 2, know these evidences so that if you are taken into the discussion, you can justify the rule with evidence. So thank you for watching this. And if you have any question, you can drop in the comments.